And maybe you already recognize that, but the research seminar is on atopic dermatitis, which means that we talk about allergy. And basically this introduction lecture will help you a little bit to know more about allergy in the way we discussed that already in the hypersensitivity lecture. You know that allergy belongs to one of the hypersensitivities, and we discussed in the previous lecture already that allergy belongs to the type 1 or type 4, and also we noticed in the previous lecture that autoimmune disease belongs to hypersensitivity reactions. So today you have to think about, later on in the research seminar, about how you approach research in allergy related to atopic dermatitis. And there should have been a paper on Blackboard, but I noticed that it was not present and I could not come into Blackboard this morning to do that. And so basically I will give the reference, and there is time between this lecture and the research seminar to go over that paper if you want to do that, somewhere on your own laptop or maybe somewhere in the library. It is advised, but if it's not possible, okay, then I can accept that you could not do that. But it will help you to understand a little bit the topic of the research seminar. So let's focus, and I think it's a short lecture. It just focuses on some aspects of allergy which you have to know related to mechanisms and related to the pathways which are leading to clinical symptoms. So this lecture was prepared by Jacqueline Poot. She left, so we could not let her give this lecture. She left to Scotland, and basically that was not capable to let her come over. So today I will present the lecture with some modifications related to the aspects that I think are useful for you to understand for the research seminar. So if we talk about allergy types, and you should recognize that from the previous lecture, we talk about allergy types like the type 1 and the type 4 hypersensitivity reaction. And you know that the type 1, and we come to that later, is mediated by IgE, and the type 4 is mediated by cells. And in some cases, we will see that even in the type 1 allergy reaction, there is also a late phase which is mediated by cells instead of by IgE. So if we talk about immediate hypersensitivity, then we have to discuss things like anaphylaxis, asthma, and you probably recognize asthma because it was already in the assignment as an atopic disease with the involvement of IgE. Allergic rhinitis, which some of you will know as hay fever. If you suffer from that, basically the original and the clinical name is that you suffer from allergic rhinitis. We have to know about food allergies, and we have to focus a little bit on the skin, because that's one of the topics of course also on the atopic dermatitis. And we will know that urticaria and eczema are expression forms of this type of allergy on the skin. And then the T-cell mediated hypersensitivity type 4 contact dermatitis related to, for example, nickel allergy or latex allergy. That will not be a major topic of this lecture because it will not be involved in the research seminar. So this is something that should be familiar with you. If we talk about immediate hypersensitivity type 1, then we know IgE is involved, and this is the pathway to come to the IgE production. So first there is exposure to the allergen, and that first exposure is sensitization. So your body gets sensitized for the allergen. And we know that if an allergen is coming in, and we don't know why a person is responding to the allergen, because not everyone is responding to allergens. You should not respond to allergens. They are innocuous materials, so you should not respond. But if you respond, and we will discuss a little bit why some persons respond and other persons don't respond. But if you respond, of course, then you know that there is activation of T helper 2 cells. And they stimulate, in the pathway of the immune response, finally the production of IgE. And you see over here how that works, because you trigger somewhere with the allergen the Th2 response. Th2 cells, they are specifically defined to create cytokines which drive the immune response towards Th2 response, in this case IgE production. So here you see that when T helper cells and B cells, which recognize the allergen, are coming together in the interaction of B cells and T cells in the pathway of the immune response, then the T helper 2 cells they give cytokines and they give signals to the B cell to switch from the original IgM production, because B cells always start with an IgM production, but with the help of the alpha 2 cells, the switch is from IgM to IgE. And if, in this case, it was not a Th2 but a Th1 cell, then the B cell is triggered when it responds to an antigen to switch from IgM to IgG. So the T helper cell type is really important for defining which final antibody type is formed. And here, by using the Th2 cell for stimulating the B cells with cytokines, the B cell switches from IgM to IgE, and the B cell plasma cell, which secretes the antibody, then is producing the IgE in the soluble form, so it can be used. Here you see that when the IgE is formed, then IgE is capable to bind to the Fc epsilon receptor 1, which is mainly expressed on mast cells and cells that are involved in an allergic reaction. And what you see over here is that in the first exposure, so in the sensitization phase, then finally the IgE will bind with the Fc part to the Fc epsilon receptor, and now this mast cell is ready to respond to the allergen when the allergen is coming into the body. So what you see over here is, this is the end product of the immune response, production of IgE. And if the allergen still is present, of course, you get also activation of the mast cells through recognition of IgE to the antigen directly, but mostly when you have hay fever, the first time, the first year that you are sensitized, you don't have the symptoms. The symptoms will come 1 year later when these cells are still present and the IgE is still on top of the mast cell. So when you later on after sensitization are exposed, so that's a challenge, then of course you have your mast cells, which those IgEs against the allergen on top of the membrane, and now the allergen can bind to the specific IgE, which is bound to the Fc epsilon receptor, and of course that triggering, that binding leads to triggering and signaling by which the mast cell is releasing its granules with the content, the mediators like vasoactive amines, like histamine, lipid mediators, and also cytokines. And this pathway, so the direct release of specific vasoactive amines, like histamine, that creates the immediate hypersensitive reaction, which occurs minutes after that you encounter the allergen. And that's the first immediate reaction, of course. Because of this activation and the cytokines that are released, there will be also triggering for cells, and we will find out later how it works, by which after hours there will be a late phase reaction, which basically is involving the leukocytes which mediate the local inflammatory reaction. So this is the basic schedule which is always present when you are talking about type 1 allergy and the involvement of IgE. So we discussed this picture in a little different conversion already before. Here we recognize an immediate reaction to an allergen which has been given to the person. So this is probably a kind of skin prick which has been given, and then you get this reaction. But you know that also after hours there will be a much bigger lesion which is involving also leukocytes and creating edema and a large swelling. And if you check this in patients with asthma, who of course are also allergic for many of the allergens like cat allergens or house dust mite, then you can measure the effect of the reaction in the inspiration volume, which is expressed over here. So this is the forced expiration volume. Sorry, I'm saying inspiration, expiration volume. So they ask the person to really breathe out very forced. And then you see that in the immediate reaction, when you here apply the antigen, then there is a rapid decrease in the expiration volume. Here it's from up to unit 400 to the unit of almost 20 or 30. And then of course that is recovered, but then you see this is minutes, 30 minutes you have this first phase. And then after hours you see there is a second decrease in the expiration volume, which is mediated by the late phase, so by the inflammatory reaction mediated by the leukocytes, which of course are all involved in producing cytokines and producing also the spasm of the bronchi. So just to illustrate how you can measure that in the breath volume. So the immediate reaction involves a couple of steps and a couple of mediators. So we know it's dependent on sensitized mast cells which have been sensitized by an immune response, and mast cells that by that sensitization express on the surface bound IgE. There is release of preformed mediators by the mast cell after activation, histamine, which causes vasodilation. It causes also vascular leakage, so you get edema formation, and in case of asthma also bronchoconstriction. There is also a rapid synthesis of lipid mediators by mast cell activation, leukotrienes, and these are involving prostaglandin D2, which leads to vasodilation, chemotaxis, so it attracts leukocytes, and also, of course, also bronchoconstriction. And the leukotrienes, which I mentioned over here, they are involved in immune reactivity, and they activate prolonged bronchoconstriction, so it keeps the process going on. So here, this is a skin test in which a person has been applied a couple of allergens. Here, all these 1, 2, 3, 4, and 5. This is just locating the place, and there's no testing. If you then apply the allergens, then you see that after 5 minutes, there's already, for some allergens, there is reactivity. So you can then define to which allergens the person is sensitized and is allergic. And if you wait for 15 minutes, you can easily see that there is a kind of heave coming up. So the person who's measuring the reactivity is saying, okay, I check the heave, and you can see when you check the heave, you just circle the heave, and around that there is still redness, but you measure the reactivity by measuring the surface or the rim around the heave, and that's shown over here. So then we have also the late phase reaction, which is not very important in such skin testing, because you know when the first reaction comes up that the person is allergic for those allergens. But of course you know that in a real allergic situation you get also the late phase reaction. And that reaction is of course activated by the immediate type reaction, so by activated mast cells. And then you see that the mast cell production of IL-1, 3, 4, 5, 6, and 13, and maybe there are many more, that is important because those cytokines, they trigger local inflammatory reaction. And you see an important one is also TNF, which is formed. And TNF is a major trigger for endothelial activation that leads to the expression of adhesion molecules. And we know also that in addition to adhesion molecules, there will be local chemokines produced, and that leads to the recruitment of leukocytes. And then you get in the late phase, you get attraction and immigration of neutrophils, eosinophils, by the chemokines eotaxin and NCP5. And you get, of course, also that the Th2 cells are recruited. And they use also the chemokines eotaxin and NCP5. So the whole process now is involving also cellular reactivity. And then the late phase sometimes may occur without an immediate phase. And that means that the immediate phase is not so strong that you can measure it, but still there is activation of the late phase, and then you recognize that after a few hours there is a late phase which comes up with an absent or very low first phase. And of course, in the late phase, it's again the cytokine of the Th2 cells that induce this late phase. Okay, so what about anaphylaxis, asthma, allergic rhinitis, food allergies, and eczema further on? So anaphylaxis is basically that you directly respond to something that comes into your body, and that may be non-inhaled allergens, and it's a very quick response. So you probably know that from venoms, from bees or wasps or snakes, and you directly develop an anaphylactic shock because the reaction is so strong that you directly have all the symptoms which are available. And that will be a systemic reaction. So the shock is mediated by a rapid decrease in blood pressure, so your brains don't get enough oxygen and enough supply, so you get in shock and you may be unconscious. Edema formation, that's mostly at the site where the sting or the bite is present, so it may be subcutaneous. It may be also in the larynx if you respond to, for example, drugs or to some of the very dangerous food allergens, peanuts. There will be constriction of the upper and lower airways, so you get out of breath. There will be hyperperistalsis of the gut, so the gut is really making much more movements than normally. There will be mucus formation in the airways and the gut, which is all a response on the direct aspect of the encountering of the allergy. And there will be urticaria, so the real recognizable skin lesions in the skin, and mostly these are hives, so these are the increased skin areas. The therapy is epinephrine of adrenaline, and basically that is really helpful to give the bronchodilation and the vasoconstriction. And that's required because the vasoconstriction is of course very good for getting blood pressure again, and the bronchodilation will help you to get a better possibility for breathing. So here you see a person who's giving the EpiPen, and some persons that are allergic and have those problems with anaphylaxis. They have with them the EpiPen, and if they have such a problem that they are getting the allergic symptoms, then they can directly give themselves an injection with epinephrine or adrenaline. So what about asthma? We discussed that already a little bit before, and you will tell about that this afternoon in the assignment presentations. So asthma is, as you know, a reversible airway obstruction. It is involving allergens. Sometimes people don't know exactly which allergens, but there are mostly allergens involved, and those persons, they have the problem that the allergen, the allergy may sometimes induce the asthma symptoms, and the asthma, when it's maybe due to coldness or other environmental triggers, will also luxate the allergic reactivity. There is chronic inflammation mediated by Th2 cells, eosinophils and basophils, so that's basically related a little bit to the late phase reactivity. The recruitment of those cells leads also to inducing the repeated hypersensitivity responses. So in that case you see that it's a kind of ongoing circle, it induces the symptoms. There will be smooth muscle hypertrophy and reactivity. So that means, of course, that you get the asthma symptoms, you get your asthma problem. The therapy, as you know, is an anti-inflammatory and smooth muscle relaxation. In the case, we discussed a little bit what type of possibilities there are for helping persons with asthmatic symptoms. And of course, we will discuss that later on. It's important to down-regulate the inflammatory response and to cause the muscle relaxation to get a better breath in your lungs. So this process is described over here. So the acute response, you get the release of inflammatory mediators. They cause increased mucus secretion, smooth muscle cell contraction, leading to airway obstruction. So then you have your asthmatic symptoms. And here we recognize the mast cell with the IgE on top, and this is maybe the allergen that is luxating and inducing the asthmatic response. There will be recruitment of cells from the circulation. So if this is occurring, then there will be recruitment, and endothelial cells are activated, express adhesion molecules, express also the appropriate chemokines. So there will be recruitment of T helper cells from the blood, and they migrate out in the tissue, and then you have the Th2 cells produce their luxating cytokine profiles. And then, as you can see, the chronic response is caused by cytokines and eosinophil products. So you get a lot of other cells that are recruited, and now we have a real strong inflammatory reactivity with the involvement of mast cells and IgE and the allergen, with Th2 cells that come in and produce the cytokines, and in that way they create a kind of pro-inflammatory stage over there by which other cells are attracted, and the inflammatory response is luxated and very strong. So allergic rhinitis, We discussed that as being hay fever as an example, but you know that you may be allergic for a lot of allergens in that case that cause allergic rhinitis. Maybe house dust mite, which is a very particular one because that's present always. You may have that in your house, in your bed, whatever. But it may be also plant pollen, and you know that the plant pollen, they are just present in the season. So that's a kind of wave. When the season is coming, you have your allergic rhinitis. When the season is over, there are no plant pollen, you are happy and you are healthy again. But if you are suffering from allergic rhinitis due to house dust mite, it's good to clean your bed and to keep your house very clean, because that will prevent you for getting the allergen into your airways. Now the pathophysiology, of course, is, as we discussed before, it's mucosal edema, leukocyte infiltration with the involvement of eosinophils, mucus secretion, and there are polyps which are present over there, edema polyps, which are having, of course, the fluid and the eosinophils. You can see that in pathology. What you do when you have these kind of symptoms, you use mostly, if you are not having very much stronger drugs available, then you mostly use the antihistamines. And people who have hay fever, who are suffering from some of the allergic rhinitis allergens, they know that they have the possibility to go to the pharmaceutical company or shop and buy those antihistamines. What about food allergy? Well, that's a very important one because food allergy is very various in symptoms. Peanuts are very dangerous. There is something in peanuts which triggers a very rapid and very high allergic response. But it's, of course, also based on the same mechanisms and the same aspects that were discussed before. You have release of mediators from mucosal mast cells. Now it's specifically mucosal because you encounter your food allergens, of course, through the mucosal, oral, nasal, or the oral pathways. There will be peristalsis, so your intestinal tract will contract, fluid secretion, and there may be also, as a kind of side effect, there may be urticaria on the skin. So even when you have food allergens, it may be that you express the allergic reaction also on the skin, which is possible because the IgE, which is produced by the food allergens, of course, is something which is soluble, and it may migrate to all the mast cells in your body. It's not always present, but it may be because mast cells in the skin also have the same possibility to bind the IgE as the mast cells in the mucosal tissues. The most common allergens, as I mentioned, peanuts, very dangerous, and you know that from the case. You can easily die when you get minutes amount of peanut allergen. Shellfish, and again, minute amounts can cause very severe systemic reactions, and we know that as anaphylaxis. So in the skin, and that will be related also to the research seminar, you will recognize the allergic response by the development of urticaria. You can see it over here. It's a kind of rash with some hives present in the skin. It's an immediate reaction based on histamine production. It disappears within hours, and the treatment is, of course, like all those type 1 allergies with antihistamines, if it's a not very severe immune response. You may have eczema, which is different from urticaria because you have more, let's say, lesions which epithelial damage, and here it's not so much damage, but here you have, of course, also the damage. Eczema, you know that it's not very nice to have that because it itches and gives a lot of problems. So that's a chronic reactivity. Major involvement of TNF-alpha as a cytokine and IL-4, and that means, of course, that you talk about the Th2 response. Recognizable because type 1 hypersensitivity is mediated by Th2 cells. It's a chronic inflammation, so it keeps on for a very long time. You can treat it, of course, but if you don't treat it, it will stand for a very long time. And because this is a very inflammatory driven response, the antihistamines are not as good as in the first phase reactivity. So you treat basically the chronic inflammation by using corticosteroids, which dampen all kind of immune response aspects. So that's a more severe treatment, and you cannot get your corticosteroids without a physician. But you can buy your antihistamines easily without a recipe in the pharmaceutical store. So therefore, if you have these kind of problems, you have to go to a physician to at least present your problems and to find out if he will give you the recipe for corticosteroids treatment. Then we come to something which is a little bit more scientific. Why do we develop allergy? And of course, basically, why don't we develop allergy, and what is the mechanism by doing that? Well, there are some aspects which is important for that, because the cells that are involved in an allergic reaction, of course, are not meant to drive allergy. They are meant for doing something good in the immune response. So we should know a little bit what is the real role for mast cells besides inducing allergy. What is the real role for eosinophils and the real role for IgE in aspects which are related to good immune responses. Well, now we go to the main point. Type 2 responses are very good for parasitic infections. And you can see that over here. Those cells and those antibodies we just described play a major role in combating parasites. And you can recognize that the mechanism by which that is done is something different than what we just saw as a response of IgE and allergy. But it is important that if IgE is present on a certain parasite, then there is the possibility that eosinophils, this is a larvae of a parasite, and you can see here many eosinophils are sitting on top of the larvae. They're trying to attack the larvae, and they do that because the larvae is expressing the IgE. The IgE is recognizing larval antigens. So now this larvae is covered with IgE, and all the IgE Fc parts, so the tails, are sticking out. And the eosinophils, they have an Fc epsilon receptor, like mast cells, and they can bind through recognizing the Fc part of the IgE to the larvae. And then, of course, they're capable by ADCC, is antibody-dependent cell cytotoxicity. So they expel the granules, it's an eosinophilic granulocyte, so it expels the granules, and the granules are capable to kill the parasite. And in that case, you see that it's important that the killing is mediated by the fact that IgE is on top of the larvae. So now we recognize a good function of the IgE. The other thing is that mast cells, they create mucus secretion. And if you have, for example, parasites in your gut or in your airways, and most important is in your gut, then there will be mucus secretion, and the mucus is a very good way to rapidly expulse the parasites. They are not capable to stick in the intestine because the mucus and the fluid that has been produced is taking the parasite to the end of the intestine. So you basically poop out the parasite if things go well. So now you see that mast cells and IgE both have a very important function in combating parasites. In the innate immune system, well, we know that innate immune system comprises also the complement cascade, and if in a certain reactivity to parasites, complement is activated, then there will be production of C5a, that is a complement kind of chemokine, and then mast cells will be attractive and they will also be activated. Of course, also TNF is produced because each immune response produces mostly also TNF mediators, TNF cytokines, and the TNF is rapidly capable to induce adhesion molecules on local epithelial cells or along epithelial cells, and there will be an influx of neutrophils. And then you recognize that basically you have a couple of mechanisms which all are deleterious for the parasite, so you combat the parasite and you will be healthy. So why do we develop allergy? So basically we have the Th2 response with all the involved molecules like IgE and of course also the molecules released by the Th2 cells for combating parasites. This is an helminth, which is, as you can see over here, looking very dangerous, and it's capable to stick with this kind of teeth in the intestine. And then it's a parasite that should be combated, that's okay. But we are also allergic for example, cat hairs. That is not what we want, so we recognize how this combating is a good response, but allergic for some molecules like cat hair molecules is not what we want. So why do we develop these allergic responses? Well, you may be susceptible, and the way we are sitting over here, we all have different genes, and your gene pattern, your genome, of course, is important for defining if you have the possibility to develop allergy. So there is genetic predisposition. We know that because allergy and atopy, which is the IgE-mediated diseases, runs in families. So apparently there's something in families like genes, which are important because in families you share a lot of genes, and apparently when you share some genes which are related to allergy, then many persons, or at least more than normal in families, there will be allergic disease. Well, it is mediated by autosomal transmission and probably is multigenic. So we see that it's not so that you can define a certain allergic gene and you can type a family and say if you have the gene you are allergic. It's multifactorial, so you need also multigenic background for developing allergy. Target organs in atopic disease are variable. You may have lung pollens, asthma, but you may also have eczema, which is basically a skin allergy. Related to the environment, there's rapid increase of allergy with industrialization, so it looks a little bit like environment and pollution may be important for triggering genes, and in that case also triggering induction of allergy. And there are of course risk factors, and you recognize of course the most important one, which is smoking, especially during pregnancy, because it appears that during pregnancy there may already be a very important trigger to the fetus immune system to develop these kind of allergic aspects. Small families, in which basically you have less outbreath, and of course rural versus urban. Are you living in the countryside or are you living in the city? And all these things are just factors that are taken into account when you calculate if a person is having a lot of risk factors available, and the more you have, of course, the more you have the possibility to develop allergy. So what about the genetic predisposition? What kind of molecules are involved, and which means which genes that lead to the production of these molecules are involved? So IL-4, of course, is very important. IL-4 drives the Th2 response, drives the production of IgE. And there are already polymorphisms detected, and they are found related to promoter variants. And apparently when you have a variation in promoter molecules, that may lead to a variation in expression, because you need the promoter molecules to lead to finally the protein production. The same holds for the IL-4 receptor alpha chain. There is variation in that, and you can imagine that some of the variations may lead to a better IL-4 and other ones to a worse IL-4. And if you have a better functioning IL-4, you may be prone to developing easily allergy. High affinity IgE receptor beta chain, well, it's the same story. MHC class 2 genes. Everyone here has a different MHC class 2 and class 1 haplotype. And some of the haplotypes contain MHC molecules which are very easily presenting allergens to our immune system. And that's just a matter of incidence. If you have that specific MHC molecule, then you are better presenting some allergens than persons who don't have that type of MHC molecules. You cannot say that's bad, because maybe that MHC class type, which is important for allergy presentation, is a very good one for also presenting bacterial or viral antigens. So you can never say that a certain MHC is bad. You just can say that it gives you kind of higher chance for developing allergy or developing back sides of the immune system. It may be also on the T-cell receptor, enhanced T-cell receptor of certain allergen-derived peptides. Some T-cell receptors are better for recognizing an allergen peptide than other ones. Of course, also the beta-2 adrenergic receptor. You may have increased bronchial hyperreactivity if you have structural differences between persons in the receptor. Maybe also a different effect of that. And also the 5-lipogenase, which is one of the important molecules. And maybe variation if you have this difference in the lipogenase or maybe variation in leukotriene production. And you noticed before that that's an important mediator of allergic reactivity. So background is important, genetics. So what about discussion why there is more allergy in this period, in this decade, we can say, or even this century? Well, we know about genetic predisposition for allergy. It can be inherited, but is this the reason for the allergic epidemic? Well, basically not, because genetic differences in evolution, they come up slowly. You don't inherit very rapidly a new gene which is expressed in a whole population of humans. So there is not an indication that the genetic background is changing so fast that we can explain that that change is important for the very rapidly increasing allergic situation in our human being. So apparently that is not possible because it's a too rapid increase to define that's related to the genetic predisposition. It is of course possible that rapidly increasing industrialization, we know that especially in the last decades there was a lot of industrialization with pollution, and maybe that pollution is very dangerous because we respond to that by all kinds of immune responses, and maybe that is not very good and we develop bad immune responses like allergic reactions. There's been a study in children from 6 to 7 years old, and there were, I think, something like 2 million children involved. It's the international study on asthma and allergy in childhood, and it shows you here in which areas there is an increase in allergy in childhood and a decrease and a stabilization. So green is just a stabilization. But you recognize that in many of the industrialized cities and countries and continents, you see an increase of allergic reactivity. So here in Europe, you recognize there is a lot of increase during the past years, and in other areas where there is not much development, like in Africa, where we have, of course, on a very high financial and economic level, you see there is less industrialization, and there will be, in this case, you see that there's not a major increase. Here, you see that in the south part of Asia also there is rapid increase in industrialization. So apparently it may be that this shows you that there are countries where the economics are coming up, also industrialization is coming up, and maybe other aspects we don't know, and there is an increase in childhood allergy and asthma, which gives you ideas about what you should maybe do to prevent that in the future. So this environment, of course, is it possible that we develop allergy because we have different infection incidents? And we know that infections may trigger for allergy. Asthma and hay fever, if you have infections, there is always, of course, by the infection, there is activation of the immune system, and that may lead to, let's say, a more dangerous allergic reaction. But there have been also incidents that infection is okay. And here you see that in 1989 there was a description that large families which were living in the countryside, so rural, they developed less allergy. And then there was the hygiene hypothesis. And the hygiene hypothesis was saying that these observations could be explained if allergic diseases were prevented by infection in early childhood. And these infections may be transmitted by unhygienic contact with other siblings. So this is leading to the hypothesis that it's good to let your young child play around with other children, let it dig in the ground and get up some dirt in which you may have all kinds of bacteria and viruses, because if you stimulate infectious responses, which basically are Th1 responses, then the increase of Th1 response may dampen the Th2 response. And we know that Th1 and Th2 are yin-yang. If Th2 goes up, Th1 is suppressed. If Th1 goes up, Th2 is suppressed. So there was a strong movement that maybe you are living too hygienic. Well, of course, there are many persons who are against this and many persons who support this. And still there is no way that we can say that this is true or not true. But there are, of course, a couple of aspects that are supporting this theory. Let's first go over the Th1, Th2 paradigm. I told you already that Th1 and Th2 are very important, different immune responses. And for the moment we know, and you recognized also in one of the first lectures, that we have at the moment also Tregs, Th17 cells, so there is more coming up than just Th1 and Th2. But Th1 and Th2 are really different in the final skewing of immune responses. So let's focus on that because most is known on those cells. And in 1989 it was by Mossman that he described the Th1 and Th2 balance and paradigm. And in human it was described by Romagna, who described it in 1992. So it is something which is expressed as well as in animals as well as in the human. So it probably is true that Th1 and Th2 are mechanisms which are driving immune responses. So this is the balance, and you know about that because if we have a naive CD4 T cell, which means it's not already a Th1 or not already a Th2, then we know that antigen presentation by dendritic cells in a certain environment, mucosal versus non-mucosal, maybe driven by other aspects than just mucosal and non-mucosal. But we know that basically this presentation is very important because this leads to the skewing towards Th1 or Th2. And of course, environmental or locally environmental substances are very important because we know if this happens in the context of an area in which there is production, for example, by NK cells of interferon gamma, then this response is skewed towards a Th1 development by upregulation of Tbet and STAT1 as transcription factors. The same holds for if this is executed in an environment in which there is IL-4 produced, maybe by mast cells, there are many other cells that can produce IL-4, then this response leads to the upregulation of kappa-3 and STAT6, which are both transcription factors relevant for Th2 skewing. And now you see that, although we don't know exactly what is the trigger which drives to Th2 or Th1, but there is something like localization of the response and like local environment which is capable to drive the immune response of Th1 or Th2. And well, this is what you know. If we get Th1 responses, then we know that we got finally activation of macrophages. Macrophages are important producer of IL-12, and IL-12 is an important one to stimulate a developing Th1 cell towards production of interferon gamma, which is, as you can see over here, again a kind of a loop by which the Th1 response is increased and is very stabilized. And then you get finally a Th1 immune response against that particular antigen that was presented here by the dendritic cell. The same holds for the Th2 response. If we have finally induction of the Th2 transcription factors, and we have still the local possibility for IL-4 from this side, but also IL-4 from the developing Th2 cells, then you stabilize this loop, and finally you get the production of Th2 cells. And then, of course, the immune response is dominant by Th2 cells, and Th2 cells secrete cytokines like IL-10, which are suppressing the Th1 response, and vice versa. So the hygiene theory was saying if you develop good Th1 responses, then you are also capable to suppress wrong Th2 responses. So what about Th1 and Th2 in hygiene? Well, if you talk about hygiene, then you should expect that in areas where there is a general burden of childhood infections, there should be less allergy, and of course there are indications for that, but if you really study that, and there have been executed several studies, you cannot scientifically demonstrate that there is a relation, an inverse relation. So more infections, less allergy. That's what you expect. And basically it has not been demonstrated in very many scientific studies. So what about specific infections? So this is generalized by just finding out if infections were present. But if you focus on specific infections like measles, well, there have been some studies, and basically there's no indication that measles infection will prevent you from developing allergy in a later period of your life. The same holds for mycobacterial infections. tuberculosis-inducing infections or other related diseases. There's even earlier contradictory effects than supporting effects. For hepatitis A, it has been demonstrated by Italian studies that if persons who are hepatitis A seropositive, so they have been encountering hepatitis A in a certain time period, there is 40 to 50% less prevalence for an IgE-mediated allergy. So here we have some evidence, that indeed some of the infections may help to finally decrease the susceptibility for developing allergy in a later phase of your life. Parasites, well, we know about that. Parasites are basically skewing towards Th2 responses, so what about that? Parasites like helminths, helminth infections, they polarize, of course, Th2 responses, because we want that. There is an increase of IgE, and we have also an eosinophilic rich infiltrate. And you can imagine that in one way that the increase of IgE against parasites is at least important for the IgE expression on the mast cells, because every IgE molecule is capable to bind to mast cells. So if you have a very high IgE response by combating a parasite, it may be that your mast cell is not having so many possibilities to also get your IgE against allergens on top of the cell. So it may dilute a little bit the IgE responsiveness of your allergic reaction. So it is known that parasites like helminth infections, they trigger regulatory T and B cells. Helminths are mostly encountered by the intestinal tract, by food, so by the digestion system. And it is known that the digestive system, all the immune responses which are related to the digestive system, induce tolerance. So what has been shown that if you have helminth infections, that it's stimulating regulatory T cells and regulatory B cells. And those are always immune dampening cells. So that may be a good effect of a parasite, a helminth infection, that you increase your numbers and your activity of your regulatory T cells. There's also modulation of innate immune cells by such a helminth infection, and then macrophages and DCs are modulated and basically modulated in favor of not developing allergy. So all kinds of effects that have been measured, and you can relate that to that it's possibly that they play a role in a lower susceptibility when you have helminth infections, or you had helminth infections, a lower susceptibility for developing allergy. IL-10 goes up and TGF-beta goes up. Well, we know that IL-10 and TGF-beta belong to the regulatory T cell repertoire. So basically also here you increase the cytokine types which are always capable to decrease immune responses. So hyper-responsiveness directed towards parasite antigens seems to extend to bystander antigens, and which means that if you are creative in, let's say, inducing kind of tolerant reaction to parasite antigens, and this is just experimentally, we don't know for sure what it means, but if a person is basically hyper-responsiveness for a parasite antigen, it may be that that hyper-responsiveness is also used for bystander antigens, an allergic antigen. This is discussable because not all helminth species do this, so it looks like not all parasites are the same, and they create chronic heavy infections. So in one way it's not easy to say let's immunize or let's vaccinate persons with parasite antigens. That will be helpful because if they then encounter an allergic antigen, then they are hyper-responsive, so they don't respond in making an allergic reaction to that allergen. So it's tricky to find out if this information leads to therapies which you can set up and experiments to find out if they are useful. So the Th1 and H2 hygiene to come on. Antibiotics and intestinal flora. Antibiotics are used, of course, for combating parasitic bacterial infections. And it has been demonstrated that persons with more lactobacilla, so the good bacteria of your commensal flora, they develop or they have less atopic disease. Antibiotic treatment in young infants, and then you of course you do something also with your commensal flora, gives an increased risk for eczema and hay fever. So apparently if you modulate your commensal flora, more lactobacilli is good, with antibiotics which kill a lot of the commensal flora bacteria, gives you more possibility to develop eczema and hay fever. So how does it work? Well, the gut, as mentioned over here, has 300 square meters of surface, 10 to the 40 of microorganisms, or kilos, and many more bacteria than the human body has cells. And of course, there's a very dynamic interaction of the flora and the immune system. It is known that your immune system is for the first time used when your commensal flora is developed. You are born without a commensal flora, but your first food already gives you the activation of your development of your commensal flora, and at the same time the induction of the immune response. So the role of the gut intolerance, as I mentioned before, we are accepting that gut immunization may importantly lead to tolerance. So in the gut we have specific dendritic cells in the gut-associated lymphoid tissue, and these have been described to be specific in the way that they are easily inducing tolerance to a certain antigen. They take up apoptotic epithelial cells, and if they do that, of course, they are capable to do something with those antigens of those cells, self-antigens. And in fact, it may be that the way that they take up the apoptotic epithelial cells with all the components which are on top of that, that leads to tolerance induction instead of activation of immune responses. And they are capable to transport this phenomenon mediated by the dendritic cells to the T cells in the mesenteric lymph node, and of course there is activation of immune response. Constitutive DC migration in the absence of strong inflammation has been demonstrated in some studies that it induces tolerance. So it may be that this is a very important mechanism by which you develop tolerance to self-proteins in your gut, and that may be the proteins of your commensal flora, because basically they belong to your body. But it's also important that this mechanism is driving that you are tolerant for dietary antigens. You should not make responses to food antigens, of course. Food is just for consumption and for making up your metabolic system. So your gut should not respond to all the different food antigens, and maybe that's important that the specific dendritic cell population in the gut is capable to prevent yourself from responding to your own commensal flora and from responding to all the dietary antigens that you encounter in your food pattern. So what about other environmental factors? Fetal origin of your proneness for developing allergy has been demonstrated. So during the fetal period, it's important that the maternal diet is influencing, of course, the development of the fetus immune system, because food is, of course, also used for the fetus. Maternal smoking, you can imagine, that's bad, and it has been demonstrated in some studies that indeed, if you smoke during your female, when you smoke during the pregnancy, that your fetus is getting triggers from that, and it may lead to later on developing allergy easier than when you don't smoke. Microbial exposure, that's related to infections, and we don't know for sure, but it's good that you should not have really dangerous infections during your pregnancy, because that always triggers immune responses, which may be also triggering the fetal immune system. And pollutants, so we know about that. PCBs, dioxins, and phthalates are very important not to encounter those during your pregnancy. What about epigenetic changes? Probably that is important, but of course it's not easy to find out which kind of epigenetic changes develop. It has been an attention point for a lot of research groups to find out if there is some really defined epigenetic pattern that is involved. So then we come to the Th2, Th1 balance and hygiene. And we know that Th70 is a very dangerous pro-inflammatory T cell, and we know that Tregs are anti-inflammatory, so this balance should be used to counterpart the balance between Th1 and Th2. We don't know how it works, but we know that if you have Th17 cells, that mainly Th1 is stimulated. And Tregs are basically important because they can downregulate as well Th1 responses as Th2 responses. So it's good to find out basically how these type of cells, Th1, Th2, 17 and Tregs, how they together are basically modulating aspects which are good for a healthy system. And here you see that if we talk about surveillance, that we know that some of the infections may be dangerous. So here infections like Toxoplasma, Candida, fungus, and Ascaris, they have been shown that they are at least having involvement and implications on the balance for good and not good responses related to allergy. And other ones like Clitoral worm and also Leishmania have been demonstrated to do something good. So also here it's important to find out which infections are good and which infections are not good, and can we use that for maybe some therapeutic or some prevention research in the future. So this is to show you how you do diagnostic with skin test. And you can do a skin prick or a skin patch. So here it has been a skin prick, so you put on top the allergen and you prick with a needle, you prick a small hole in the skin by which the allergen is capable to go inside the skin. And then you can easily find out here you have a heave, and you can calculate the heave is this circle. So you are positive for this one, positive for that one, and here is also one with a negative for 3. And maybe there are also other allergens which you don't respond to. Of course, also serum testing is possible, but IgE is not, if you just test IgE and you don't test an allergen-specific IgE. So very high levels of IgE are important because they indicate that it may be related to the allergy. But of course, you have to do an IgE-specific, an IgE antigen-specific test just to find that indeed you are allergic for example, for this or for that type of allergy, cat or maybe pollen allergens. This is what you do by skin testing. You apply basically your allergen inside the skin. It gives you the risk for anaphylaxis. That's why if you do that, you always have to sit in the hospital for a while, because if you develop anaphylaxis, you are in the hospital, so you can easily be treated. So there's a risk for anaphylaxis. Mostly it doesn't work so bad. It's very high sensitive, so it's good to find out that with this reaction you know which allergen you are allergic for. Of course, the patch test is not as easy inducing direct phenomenon, because the patch test means that it's on the skin, but it's good that it can be used for typing if you are having type 4 allergies, and it's good because it also demonstrates if you have the late phase of type 1, that you have to wait a while because the patch test is not directly after 30 minutes already capable to be read out. If you do serological testing, you can test for specific IgE. So general IgE is not very indicative for being allergic, but it may indicate that you might be allergic. It's good if you specifically test for specific IgE, so allergen-specific IgE. That's safe because you just take blood from the persons. It's convenient. You can test many antigens. There are kits available by testing many of the antigens, like cat antigens, house dust mite, and some of the pollen antigens. It's less sensitive than skin testing because you are just doing something in vitro. It's not related to clinical symptoms. And in food allergy, it gives you many false positives. So that's not good. But at least it gives you, the negative ones are reliable. If you don't have a reaction, then you don't have a food allergy. But if you have a reaction, maybe that's not related to symptoms, and then you talk about a false positive one. So therapy, histamine receptor antagonist, we know about, that's the antihistamine treatment. Leukotriene receptor antagonist, corticosteroids, anti-inflammatory. Calcineurin inhibitors, decreases IL-2 production, so it decreases also the activation of T cells. And of course, anti-IgE therapy, biologicals, omalizumab, an antibody which is taking out all your IgE, so also the IgE which is responsible for your allergic reaction. What can you do? You can better, of course, avoid the allergen. And if you cannot do that and you have strong symptoms, it may be good to do immunotherapy. Try to immunize with the allergen against a response that the allergen normally induces. So therapy with corticosteroids, they inhibit the synthesis of mast cell mediators. You can also stabilize mast cells so that they don't release their granules by glycate, which is a compound you can give and then the mast cell is stabilized. It's not as safe as you think because basically the stabilization just occurs for a while and afterwards you are again sensitive for development of allergy. Leukotrienes and histamine receptors can be blocked. And of course with epinephrine and adrenaline, you can, as you can see over here, if you use those agonists, then you inhibit the effects of mast cell mediators. And that's what you have in your APP. You do this and then you have directly the effect of the receptor agonist pathways. So immunotherapy, you can do vaccination with specific allergens. If you do that, it is effective in allergic rhinitis. So persons with hay fever frequently they go to kind of a treatment in which they get vaccinized for their allergen. For venom allergy, you can imagine venom allergy is the poison of a snake. So if you vaccinate and you have antibodies against the venom, then it's very easy that you are not developing the symptoms of the venom. In asthma and atopic dermatitis, it has been applied, so you can do it over there. And basically what you do with allergic rhinitis and vaccination is that you try to make an immune response, which is giving a counter response than the allergic response. And mostly when you do vaccination for your hay fever, you get your injections in your shoulder. So that's a completely different route for activation of the immune system against the allergen. And maybe that's the reason why it leads to another immune response. So not a Th2, but a Th1 response. And finally, you know if you get a strong Th1 response, then you suppress your Th2 responses. So I think this kind of vaccination is effective for 60 to 70% of the persons to do that. So it is worthwhile to go for a year in this kind of treatment and find out later on that you don't have your hay fever anymore. It modifies also progression of disease, so it helps, not always is capable to cure you, but it may at least modify the progression by new sensitizations, so you are not sensitized again, and by decreasing your development of asthma from rhinitis. And that is very good because mostly you have strong symptoms when you have new sensitizations for new allergens, and later on, of course, you have the reactivity of that. And of course, your frequent asthma symptoms are not very nice, so when you can do vaccination which decreases these kind of things, you will be more happy and more healthy in your life. So in summary, some small remarks that was made by Jacqueline. Atopy is susceptibility to immediate hypersensitivity exposure to allergens. It leads to Th2 responses and IgE protection. Allergen binding to IgE on mast cells, that causes the acute phase release through mediators, histamine. And the late phase reaction is due to cytokine production and the influx of inflammatory leukocytes. So you produce an immune response to all kinds of leukocytes involved. An allergy can manifest itself in different organs, symptoms, maybe it's systemic, and sometimes it's on the skin, or it's just in the lungs, and then you have your asthmatic problems. Okay, thank you. So this is already on Blackboard available. So if you have time